Thank you, ladies and gentlemen, for joining this particular special interest group meeting, the first of its kind, which is being held at APIS, ISPE Joint Meeting of 2024. And I think the whole background and idea behind the special interest group meeting is to share interest and expertise among group of people who have a common interest. And furthering this could have unlimited possibilities, really. And that's where we wanted to start this as Phaeochromocytoma and Paraganglioma as special interest group meeting. Joining me with for this particular meeting is Dr. Professor Stephen Waguspak. Stephen is professor at MD Anderson Cancer Center and works in Department of Endocrine Neoplasia, has a huge interest and area of expertise in different endocrine neoplasias, Phaeochromocytoma being one of them. Roderick Clifton Bligg comes from Sydney, Australia, from Department of Endocrinology, and he co-heads Cancer Genetic Laboratory at Royal North Shore Hospital, Carling Institute at Sydney. Vijay Asarthi, to my right, my colleague and a very dear friend, who heads Department of Endocrinology at Vaidehi Institute of Medical Sciences and Research Center at Bangalore, India. And to my left is my very own Manjri. Manjri is the most learned, bright colleague that I have pleasure of working with in Department of Endocrinology at KM Hospital, Mumbai. And Maria Craig, who's on stage with us, president of APIS, probably doesn't need any introduction. It's with her and Ahila's efforts. It's with her and Ahila's efforts that this particular genesis of special interest group has come forward. And we have Jenny, who has been able to join with us online. Jenny is President-elect APIS, and Jenny, thank you for allowing this special interest group meeting being fructified. Ahila, our very own Indian Society of Pediatric and Adolescent Endocrinology President, the ever lively and ever accommodating and a most positive mindset of an individual, was the most helpful to put forward this entire concept and bring it to attention of all the ISPE members. So Ahila, thank you very, very much. So starting from this particular introduction, what I'd like to tell you is how this whole concept in next 1 hour is structured. What we have tried to do is put together a case-based discussion to bring together the various challenges encountered in patients with Phaeochromocytoma and Paraganglioma. Manjri, myself, and Vijay as well, we all come from this particular institution, KEM Hospital, which is in Mumbai at the west coast of India. Ours is a referral center, and because of our special interest in patients with Phaeochromocytoma and Paraganglioma, we've seen a fair number so far, about 650 patients so far with Phaeochromocytoma and Paraganglioma, and we'd like to share some of our strengths and our challenges that we have faced. So here it goes. Manjri, my colleague, is going to now take over to tell us about this very interesting case.
Yeah. So let us begin with this case of a 13-year-old boy who has a very common complaint which a 13-year-old boy would have of abdominal pain for a duration of 2 months. So because of the chronicity of the pain, he is imaged, ultrasonogram is done, and an incidentally picked up right adrenal lesion is found, which is measuring almost 7 into 5 centimeters. During this evaluation, he is also found to have an elevated blood pressure to the tune of 180 by 110 millimeters of mercury. So therefore, he is further referred to us at the Department of Endocrinology to rule out any cause of endocrine hypertension. So when we evaluate him, he has no family history of similar complaints. His height and weight are pretty much normal, but he is definitely hypertensive both in the supine and the standing position, and he also has a significant postural drop of blood pressure, whereas otherwise his examination is normal. So basically, he's referred to rule out the presence of a phaeochromocytoma because of the adrenal lesion which is picked up. So, based on this background, I would like to ask Dr. Stephen, when do you suspect a phaeochromocytoma or paraganglioma in these patients presenting to us?
Thank you, Manjari, and good afternoon, everyone. Well, you've made this one easy because we already have a little bit of sneak peek into what's going on with this young man. But in general, just talking about pheochromocytomas and paragangliomas in children, they are quite rare. And if you look at all hypertensive children, about 4% of those will have an underlying catecholamine secreting tumor. So, quite rare. 4% of all hypertensive children, which is not that many to begin with. And just to keep in mind, again, this patient made it a little easier presenting with severe hypertension and abdominal pain. But sometimes the signs and symptoms of catecholamine excess can be more subtle in children. And, of course, we expect the typical, findings, but because most children have noradrenaline producing tumors, they don't typically have the classic, signs and symptoms of, flushing, headaches, and palpitations. And so they may present just like this with more sustained hypertension, but also the abdominal pain, a change in school performance, becoming more inattentive. There can be urinary issues, vision changes can be described as well. But in general, that's kind of, I guess, any child presenting with hypertension, we would think, of course, of a catecholamine secreting tumor, and then try to look for these other subtle signs and symptoms that might suggest there is a tumor there.
That's great, Steve, for sort of a starter in terms of how to present and how to suspect a phaeochromocytoma. What we have seen in our own experience is that the pain in abdomen seems to be a very dominant complaint with which these patients really come to us, and the preceding symptom complex sort of just gets interpreted only retroactively, so that their school performance, their attention was changing, or they were complaining of visual discomfort or a visual challenge or visual blurring. And when I talk to these parents, and they always say that it's because he didn't want to go to school that we thought he was just putting up these kind of symptom complex, and we did not kind of relate to it. What I'd like to suggest is majority of our children either come with abdominal pain or one of the hypertensive urgencies and emergencies. That's been our commonest presentations. And just now we are moving over to sort of starting to screen these family members who have been detected to be genetically positive, and the children are coming of age who are now getting screened, so they tend to be a little asymptomatic, so to speak, and found more on screening parameters. But otherwise, it's more like hypertensive emergencies, which has been our presentation as a first go, really speaking. The next slide, please.
Yeah, right. So that very well summarizes how a patient with a pheochromocytoma may present to us. So let us move with this patient further. Now we are suspecting this patient to have a pheochromocytoma. How do we evaluate this patient further? What kind of biochemical tests do we order? So to answer this question, I would like to invite Dr. Roderick.
Thank you. And again, it's not difficult to suspect a pheochromocytoma in this 13-year-old boy with a pre-existing large adrenal mass. Now, the biochemical tests are, of course, relying on the metanephrine and normetanephrine measurements. And whether we measure these in plasma or urine is really a shared decision between the clinician and the patient. We need to acknowledge that for plasma metanephrine and normetanephrine, there should be age-specific cutoffs. which are important for interpreting the test result. There needs to be some local expertise involved. So some centres are more expert in performing urinary tests for metanephrine and normetanephrine. Other centres are more comfortable measuring plasma. The gold standard, of course, is measuring these analytes using LC tandem mass spec, and that I think is now universally regarded as the gold standard for measuring the metanephrines. So I would discuss with the patient and his parents whether he would prefer a fasting supine blood test for fasting plasma metanephrine and normetanephrine, or whether he would prefer a 24-hour urine collection for the same analytes, and those analytes should be measured by LC tandem mass spec. I think the point that Steve raised earlier is also extremely important, and that is the a priori suspicion for phaeochromocytoma, which will be important in the post-analytic decisions. So when the a priori suspicion for phaeochromocytoma is high, then we would accept any value above the upper cutoff of the normal range as positive for a diagnosis of phaeochromocytoma. And in this young boy, the a priori suspicion for pheo is at least, in my view, at least 10%, if not higher. He has a large adrenal mass and sustained hypertension. So that's where I would start, and I'm happy to hear the opinions of the other panel members.
I think, Rory, that pretty much sums it up. And from our logistic point of view, we find it very hard to collect 24 hours urine sample. And we have erred towards looking at plasma-free metanephrines with all its pre-analytics being met with, which is a supine sample with at least 20 to 30 minutes of rest, and then collect the sample. And, we are now doing it with LC-MS-MS, which provides metanephrine, normetanephrine, and dopamine, and 3-methoxytyramine as well as a dopamine derivative. So we are trying to look at all of them, and that's where we kind of currently stand. But we find it very, very hard and probably impractical in terms of completeness of collection, the 24 hours urine sample, and we have erred more on the side of plasma metanephrine being our go-to test, really speaking. And in that context, maybe, Rory, you want to just comment a little bit further on the fact that I said that most of our patients, they present in hypertensive emergencies, or they are like flash pulmonary edema, Press syndrome, hypertensive encephalopathy. And in those scenarios, it may be a little challenging to read these values. So how would you kind of go about this particular question?
Yes, thank you, Professor Shah. That's another extremely important point, that interpreting metanephrine and normetanephrine during a crisis can be difficult, because naturally in the intensive care environment, measuring the catecholamine analytes are frequently elevated from non-tumoral causes. So in that setting, I still measure plasma metanephrine and normetanephrine, expecting them to be elevated. But the presence of the adrenal mass accompanied by the classic presentation would lead a very high diagnostic probability of phaeochromocytoma. And we would, in this setting, I would suggest this adrenal gland needs to be surgically removed in due course, but alpha adrenergic blockade will be required for some time before surgery is attempted.
Right.
Right. So keeping all the pre-analytical requirements into mind, we did the plasma-free normetanephrine and plasma-free metanephrines in them. So back then, we did not have access to LC-MS assays. So these reports are immunoassays. But nowadays, we do have access to LC-MS, and therefore we are doing that in all our patients. It's a panel of plasma-free normetanephrine, plasma-free metanephrine, and 3-methoxytyramine. And this patient had elevated levels of plasma-free normetanephrines. And therefore, the next step would be then to localize the tumor. And what would be the imaging modality of choice? Dr. Vijay?
Yeah, Thank you, Manjari, for that question. So before we move on to understand the what are the choices for imaging, we should need to understand like what are the usual locations for occurrence of phaeochromocytoma and paragangliomas. So can I have the slides, please? Yeah. So in fact, like if you look at this data from a systematic review done by us, so 45% of the pediatric PPGL patients will have a solitary adrenal, whereas 15% will have a synchronous bilateral. So around 10% will have a co-occurrence of a phaeochromocytoma with a PGL either in the abdomen or in the thorax or in the neck, whereas 30% will have an exclusive paraganglioma. So in pediatric PPGL, at least one PCC will be present in 70% and one PGL will be present in 40%. If we further look at the distribution of the PGL among them, that's the 40%. Of these 40%, 30% are within the abdomen. So whereas the remaining 10% may be extra abdominal, either in the head and neck or in the thoracic region. So it's not only to detect the primary PPGL, but also we have to look at the metastasis, which is almost possible in 10 to 15% of pediatric PPGL patients. So then what are the usual sites for metastasis? The common sites include the skeletal, followed by nodes, and then the liver and the lungs. So with this knowledge, let's look at what can help us to localize all these things. In fact, the most yielding imaging would be to perform the imaging of the abdominopelvic region, either with a CT or an MRI. So because this identifies almost like around 90% of the primary PPGL and also almost around 70 to 80% of the metastatic burden. But there comes a question whether it should be CT or an MRI. So if you look at the guidelines by the Endocrine Society, the CT is preferred in adults because of their extensive spatial resolution. In fact, whenever you talk to the surgeons, you do realize that they're pretty much looking for a CT or an MRI because they also get a good anatomical delineation and also some information about the vascularity of the tumor. And however, in children, we always want to expose them to lower amount of radiation, especially in those patients who have a syndromic PPGL, where probably we need to image them at regular intervals. In such situations, at least the MRI is the most preferred modality. Indeed, MRI also increases the specificity because of in the 2-2 weighted images, if you have something like lighting like a bulb, then we know it is likely to be a neuroendocrine tumor. In adrenal, it's going to be Pheo. Of course, we have a patient like what Manjari projected, but abdominal imaging did not reveal anything. So then we are left with the thorax, because thoracic sympathetic paragangliomas also do secrete catecholamines. And then we have to extend the imaging to involve the thorax. Again, thorax can be better imaged by a CT scan. But whenever we're looking for a head and neck paraganglioma, indeed the most preferred imaging is an MRI because it gives a typical salt and pepper appearance, at least in 50% of the patients. And especially if we do with the contrast, the sensitivity to detect the head and neck paraganglioma is much higher. So in fact, there's another scenario about the imaging. Let's say we have patient has come to us with an incidentally detected adrenal mass. Of course, we know that we have an answer to detect as a Pheo or not a Pheo by doing metanephrines, but sometimes metanephrines take a long time to reach us, or sometimes even it may be a non-secretory tumor. So can imaging help us to know whether it could be possibly a PPGL or not? In fact, the data from KEM can clearly say that, at least among the norepinephrine secreting tumors, the arterial enhancement, whether it may be an absolute enhancement or as a in comparison to the baseline, is a very good marker to identify and differentiate these tumors from other adrenal masses. And in patients with a suspected SPGL from other retroperitoneal masses, is a very useful tool to identify whether this is a Pheo or not. Of course, imaging doesn't end in searching for PPGL, so always keep an eye on the pancreas and the kidney because you may be dealing with a patient of VHL where they not only have a Pheo but also may have the associated tumors like pancreatic cysts or pancreatic NET, or also the renal cyst or even the renal cell carcinoma.
So basically, we are trying to now just collate together the summary of imaging, which Vijay has alluded to. And what one would realize that yield of abdominopelvic region being imaged, either with a CT or with an MRI, as one would consider, considering the logistics, the age of the child, and so on, is going to yield your answer in majority of the patient, because thoracic region and the neck region will barely account for anything between 8 to 10% of your lesions. Your 90% of yield is going to come from abdominopelvic region being imaged, and that is the background that we'd like you to just hold on to, because when we talk about the surveillance program for these children, that is going to come back again as a question mark for us, right? So we go for the, could we sort of consider now Steve's answer and his impression of role of functional imaging, both from the diagnostic point of view and from the map point of view of understanding the disease burden mapping, which is going to change the treatment of an individual. So Steve, what would you consider? How would you go about it? And in which patients would you like to do it?
Thank you. So, functional imaging refers to the use of, radionuclides to identify tumors that are, that take up that particular tracer. So the functional imaging in this situation, we think of MIBG, we think of somatostatin receptor scintigraphy, specifically these days with a dotatate PET CT. There's also FDG PET CT, that is another functional imaging that can play a role. And then finally, there are other tracers as well, like DOPA, although not every place has access to those types of scans. So the role of functional imaging, I view not so much to make a diagnosis, but to add information that might help management of the disease. So for example, in this case, where there's already an established adrenal mass in the proper clinical context, and I would suspect the mass looks like a Pheo on imaging as well. We haven't seen the images of this particular patient, but the diagnosis is made. We don't necessarily need a functional imaging to confirm that that is a phaeochromocytoma and that it needs to be removed. So I tend to think of it more as to answer several questions. One is, we know that in a young person, right, and I'm sure someone will talk about the genetics, but these patients are very enriched for hereditary disease that can give rise to multifocal tumors. And so one role of functional imaging is perhaps to identify other primary PPGLs about which we are currently not aware. Now, in a situation like this young boy, that the main working diagnosis at this time, we'll find out or not, would be von Hippel-Lindau disease, in which case we know that the risk of paraganglioma is actually, it's there, but it's not extremely high. But if this were not an adrenal mass, or just described as a retroperitoneal mass, then we'd be thinking of the familial paraganglioma syndromes, where we are potentially more likely to see multifocal paragangliomas. So one role of functional imaging would see, is there anything outside of the tumor that we already know about? The second is, we know that any PPGL really, and all PPGLs that are greater than 5 centimeter in size, have a potential to be metastatic. And as well described, it can go to lymph nodes, bones, and other vital organs. So an important role of staging or using functional imaging is to look for evidence of spread beyond the primary tumor, because that would change your surgical management, or, for example, in the finding of widespread disease, you might, even change your thought process in general. So, MIBG certainly can be used. I think most of us, if we have access to it, tend to prefer going straight to somatostatin receptor scintigraphy, because it is very sensitive for the detection of these tumors. But I have also learned that not all paragangliomas are positive on that test as well. FDG PET actually works very well in addition. So for centers that don't have access to somatostatin receptor scintigraphy, I think FDG PET can also be very useful in that setting. So that's the typical reason why we would consider functional imaging. Now, like I said, I personally don't do it to confirm that this is a Pheo, because I think we already know that. The other situation I could envision perhaps is if you have a patient that has a high pretest probability of having a catecholamine secreting tumor, you have the biochemical confirmation, but you really can't find the tumor. That's extraordinarily rare, but then that would be a situation where functional imaging might lead you to identify the tumor. Perhaps it's one in the thorax that we didn't know about. So that's another role for it.
Thank you, Steve. So that's a kind of a general algorithm which Steve really referred to, that we kind of generally in our institution, we've been working with SSTR-based, receptor-based imaging data and FDG as well. MIBG, of course, as a good old modality of imaging stands, but because of its planar imaging, it becomes a little difficult to read it up really. DOPA is not something that is available to us, but DOPA is considered to be a fairly good modality of investigation as well. So in this particular patient, the CT scan that we showed you did suggest that the tumor was pretty large and it was about 7 centimeter in size. And the DOTA scan kind of showed the uptake in one single area, which related to the tumor alone. And that's where we really stood. And if we kind of sort of now take it further, we call it childhood sporadic isolated right-sided phaeochromocytoma. And the question then would be, how does one propose the management plan for this patient? Rory, would you like to share your experience with us?
Yes, so this enters into a controversial area about whether preoperative alpha blockade is always required. There are two reasons to consider preoperative alpha blockade. The first is symptom control. It's, as Dr. Wagersbach has already alluded to, it's more for controlling the paroxysmal symptoms associated with adrenaline secretion, not relevant to this case, but it can be very important for symptom control leading up to surgery, which for many reasons may be delayed. The other reason for alpha blockade is to minimize the blood pressure variation at the time of anesthesia and surgical manipulation of the tumor. At some expert centers through the world, a very strong vocal group in Germany in particular are advocating that alpha blockade is not universally required so long as the anaesthetist is well informed beforehand of the likelihood of the tumor being catecholamine secreting. I have to say in my own personal practice, I routinely alpha block patients because I feel more comfortable that their blood pressure is well controlled leading into anesthesia. And there is data supporting alpha blockade minimizing hypertensive variability during and after surgery. The choice of alpha blockade it can be phenoxybenzamine or prazosin or doxazosin. Some centers through the world use the amlodipine, a calcium blocker rather than alpha blockers. I think it relies on local expertise and comfort. I think the aim of treatment is to normalize the blood pressure preoperatively, and acknowledging also that some degree of salt bathing will be required immediately before surgery because these patients are vasoconstricted and volume contracted. And after we treat the blood pressure, some degree of salt repletion is required before the patient undergoes surgery. So I guess we'll be coming to the question of genetic testing as well. Whether genetic testing has to be entertained before surgery, again, is somewhat controversial. It really depends on whether the genetic result will change your surgical approach. And that's most relevant to the genetic diagnoses where there's a possibility of bilateral adrenal disease. Now, again, I don't think for this case it's necessary to consider preoperative genetic testing because this tumor is large. We're not going to do adrenocortical sparing surgery in this case. But for smaller tumors and where there's a higher probability of bilateral adrenal disease, then the surgeon may want to consider adrenocortical sparing surgery at the first operation, given the fact that some patients may end up having bilateral disease, and avoiding bilateral adrenalectomy is useful if possible. So again, I'd like to hear the thoughts of my colleagues, but preoperative management, I think, should entertain alpha blockade, salt repletion, and some consideration about genetic testing.
Yeah, I think, Rory, that's a very, very fair sum up and experience that you've narrated. Routinely, as per the guidelines, of course, we kind of look after the the blockade for these patients who are hormonally functional in all of them. And we've not had courage to think about working without proceeding blockade for the surgical management, really, though we've had huge number of interactions with the German group, and they seemed very, very comfortable, but I think we've not mustered that courage to do that. What we kind of routinely practice as a matter of great deal of comfort after this particular set of work, which was published in 2021 from our department, is on the pink bar you can see is an alpha blockade group of patients, and the white bar represents the calcium channel blockade group of patients. And what we realize is that after the blockade with alpha blockers, even the ambulatory blood pressure monitoring at the end of blood pressure, at the end of blockade, did show up a good blockade, in spite of which intraoperative hemodynamic instability, which is what this graph represents, was very, very unpredictable with alpha blockers. Whereas with calcium channel blockers, we felt that intraoperative hemodynamic stability, and you can appreciate the flat line of the black and white portion of the diagram really out there, is very convincing. And that's where we have been using calcium channel blockers, namely amlodipine, in our patients as a preoperative measures, besides volume management and salt management in these group of patients. And what we find is both the intraoperative course and the postoperative course is rather comfortably positioned from the anesthetist point of view and the surgical intensive care point of view in the postoperative period, which is where we stand as of today. In this particular patient, Manjri will take us through the rest of the nuances, please.
Yes. So he did receive preoperative blockade, and subsequently he underwent laparoscopic unilateral right adrenalectomy, and postoperatively he was normotensive. So since he was a child, and in any patient who has a phaeochromocytoma or a paraganglioma, we would next like to discuss the role of genetic screening in these patients.
I think the very important factor is that PPGLs are one of the most heritable disorders among all the possible tumors that exist on the earth. The most heritable tumor is PPGL. Even in adults, almost like 40% of the patients will have an underlying germline mutation. So when we look at the children, so the prevalence of germline mutations are even higher. So in fact, the prevalence of germline mutations in pediatric PPGL patients is up to 80%. So obviously all these patients should be screened for genetic variants, because they not only have implications for the management of PPGLs and also for the associated other tumors. If we have to look at the classification of the tumor based on the pathophysiology, that's completely driven by the underlying genetic mechanisms. They're classified into cluster 1 tumors and cluster 2 tumors. Both of them are germline. I'm not touching much upon cluster 3 because they're most of somatic. The cluster 1 is the one where there is a pseudohypoxia pathways involved. So this may be because of either mutations in the IPAS1 that goes for HAF2 alpha, or VHL, which is required also for the HIF pathway, or could also be the energy metabolism pathway, where the succinate dehydrogenase is the most commonly involved enzyme, and any of the subunits of this enzyme can be affected that predispose to PPGL. Whereas the cluster 2 is typically the kinase signaling pathway, so which may include the RET, TME127, or even neurofibromatosis 1. The beauty is that they differ very well in their uh, secretary. Okay, so let's just focus on this. If you look at the prevalence of germline mutations, as I told earlier, it's 80%. And if you look at the distribution of individual genes in the pediatric PPGL, the majority are VHL, they're followed by SDHB in around 1/4, and 10% are SDHD, whereas the RET accounts for only around 5%, where the other mutations account for remaining 5%. So why we're interested in this genotyping of these pediatric PPGL patients? Because there is a strong correlation between the genotype and the phenotype. So if you look at the location of PPGL among the VHL patients, we know it's either predominantly adrenal disease, or even if they have an extra adrenal disease, it's almost always within the abdomen. That's an intra-abdominal extra adrenal disease. So whereas in SDHB, the extra adrenal disease is more prevalent, especially the extra adrenal, extra abdominal. Even the thoracic and the HNPGL are quite common there. Whereas in the SDHD, the predominance is in the HNPGL, though they can occur anywhere along the sympathetic and parasympathetic chain. Whereas in the RET, it's predominantly the adrenal disease. I think hardly 1 or 2 cases of extra adrenal disease you would find. Not only that, even there's a correlation between the genotype and the secretory phenotype. So the cluster 1 tumors, they are predominantly norepinephrinergic. Some may be isolated dopaminergic, some may be even non-secretory. Whereas the cluster 2 tumors are typically the epinephrine tumors where both epinephrine and norepinephrine is elevated. The other important association we are looking or trying to derive from the genetics is the malignancy risk. We know that the HDHB has a highest risk of malignancy. In fact, it may vary from 40 to 70%, followed by SDHD, where it may be around 10%. VHL may be around 5%, whereas in RET, though the MTC is a malignant thyroid tumor, is much more common in MEN2A and MEN2B, the malignant Pheo is less likely, maybe less than 3%. So another interesting phenomenon we just want to share is that like this anticipation. In fact, it has recently been reported also for the SDH variants. But what we have observed in our cohort is typically for the VHL. If you look at this data, in fact, the parents presented in their 40s with relatively smaller tumors, whereas their offsprings presented in the second decade with much larger tumors and greater number of PPGL in them. So obviously, if you have a parent who has been affected, not necessarily we have to start screening from that particular age. So since we're expecting an anticipation, we need to be a little vigilant and start screening at an earlier age.
So, Steve, that brings us to a very, very crucial part of the whole problem, the whole surveillance protocol. How intensive, how early, and what modalities are we really looking at adopting over here?
So, very important and complicated question, I think. It may seem straightforward, but in reality, I don't think it is. So, during childhood, the 2 major syndromes that we will encounter are VHL and the SDHBs, familial paraganglioma syndrome type 4. So I'll tend to focus on those. For the audience, most people think MEN2A or 2B and RET, but remember that's a very small minority of phaeochromocytomas that present during childhood. But just to cover that, right now at least there is an understanding of genotype-phenotype correlations in RET, and so typically the higher risk codons for Pheo, there's an age of screening starting at a younger age, around age 11 for the 918s and 634s, and then all of the other mutations later in life. But it's a very vague recommendation, and I think we all kind of screen periodically because we're checking calcitonin levels anyway. For VHL, the current, the VHL guidelines were recently re-looked at and republished, and it's currently recommended that children with, now these are children who are known to have a genetic, so they have genetic VHL, right? They don't yet have a clinical manifestation. So it's recommended that assessment of vital signs and symptoms be started at age 2. There have been at least 1 or 2 cases of 2-year-olds with symptomatic pheochromocytomas. And then formal metanephrine screening with plasma metanephrines, as most of us would probably do, starting around age 5. And in VHL, importantly, we don't incorporate radiologic screening specifically for pheochromocytoma paraganglioma. So it really is just the metanephrines. But in VHL patients, remember, you'll get a free look at the adrenals because they're having periodic abdominal imaging regardless to look for renal cell carcinomas and pancreatic tumors. The more complicated group, I think, is those children who have familial paraganglioma syndromes. And there are, some guidelines out there. There's a recently published paper on STHB. And a few years ago, there was a broader publication about surveillance in STH in general. The problem with that paper is they kind of lumped all the STHs together. And I think that's very challenging because, for example, STHA, STHC are quite rare. And at least what we're learning in the adult population is we're seeing a lot of incidental STHA patients who are found to have that mutation on genetic testing done like as part of an oncologic panel. And so the significance of finding some of these, it's really challenging to know what that means for a child who also has inherited that particular variant. So for example, the UK has come up with their own guidelines suggesting that patients incidentally found to have SCHA should not even have testing if there's no really compelling reason to do it. But to focus on STHB, because what we're going to primarily see and have to surveil during childhood, it's patients with STHB. And right now, it's generally thought that testing should begin around age 5 or 6. I think it's officially 6, but I tend to think around age 5, and that's primarily based on the youngest ages of presentation of PPGL. And then because tumors in familial paraganglioma syndromes are not always functional, you have to also layer imaging. So it's not just biochemical testing, it's also imaging to look for the non-functional tumors, which, we have seen some cases that have patients presenting with widely metastatic disease with a non-functional SDHB mutated paraganglioma. So it is quite important because those do arise in childhood and can cause quite a lot of morbidity for the patients. So that is where the challenge comes. And I can tell you what I do. I do things a little differently than maybe the guidelines. But in general, the guidelines recommend every other year whole body imaging, and many centers are going to a whole body MRI if you have that available. It's a fairly short protocol, only about 60 minutes, and basically looks at the patient from head to toe. And so you cover your head and neck, you cover your chest, as well as the abdomen and pelvis. The issue with children is that, at least my philosophy, the odds of a child having a non-functioning, clinically relevant tumor at a young age doesn't warrant sedating a child to do an MRI. So I tend to offer a whole body MRI in older children when they are able to hold still for an MRI without needing sedation, because again, the risk is going to be low that they have a tumor. So I think we don't need to force every child to undergo unnecessary risks of anesthesia. And then in the youngest children, I actually will do biochemical testing, and I will just layer on an abdominal and pelvic ultrasound. My thought process being that clinically relevant tumors should be able to be found just with ultrasound. And so that's my approach. The guidelines are a little different. I think everyone agrees that annual biochemical screening is important. Of course, symptom assessment. And a struggle that I have, and I'm interested in everyone else's thoughts too, is, these patients are at risk for other tumors. And, VHL is well established in terms of how you screen, but familial paragangliomas are not, in terms of, how often do you need to screen for renal cell carcinoma, or how do you actually screen for gastrointestinal stromal tumors?
Right. Steve, I'm glad you kind of addressed this aspects, which are like really, really challenging, both from the family's point of view and the physician's point of view, because it is not easy to it's not easy to kind of keep sort of track of the whole thing and yet not traumatize the family. I mean, it's kind of a huge burden that you lay down on the family. So that is a definite challenge that we are looking at, and balancing act definitely tends to be difficult. But yes, I totally relate to your philosophy of having a little more balanced approach out there. At this junction, may I just request Rory's comments? Rory, SDHB gets laid out very differently projected in terms of risk of malignancy, and also this phenomenon of anticipation gets projected very differently. So I think in some of the recent publications there have been very different thinking about it, and would you like to tell us more about that?
Thank you. So anticipation is the term that's applied for when the offspring develop disease at an earlier age and at a greater severity than their parents who carry the same genetic mutation. The difficulty with establishing anticipation is the power of the data set that we're looking at. And for SDHB, we all have patients where we've looked after children or young adults with tumours related to germline mutations in SDHB. And when you do the cascade testing, you'll find their parents and grandparents carrying the variant, the pathogenic allele, but with no evidence of tumours. And so this is one of the difficulties in looking after familial paraganglioma syndrome 4, is that the index case can have widespread disease, and yet their family members may have no evidence of disease on imaging. Whether that's an aspect of anticipation, I think, is controversial. I think that it's difficult to interpret earlier onset in an environment where we actually have availability of screening, particularly genotype-directed screening. So we are looking for tumours in younger people, and that interferes with the scientific assessment of whether anticipation is truly present. What we did find and publish recently is that, of course, for autosomal dominant disorders, we expect a 50-50 inheritance pattern. And we reported an interesting observation that for SDHB, at least, it looked as though the inheritance of the pathogenic allele was skewed to around about 60% of the offspring carrying the pathogenic allele rather than the expected 50%. That's not anticipation. That's what we call transmission ratio distortion. It's a single publication, but I'd be very interested in that observation being validated by other groups, and in particular yours, Professor Shah. I think you've got a unique opportunity with such a large amount of data that it'd be very interesting to look at the experience of KEM.
Right. I think in interest of time, I'll have to stop the case discussion here, and I'd love to keep it open for the interaction with the audience over here. So in the case, we try to cover all the challenges vis-a-vis the clinical presentation, when to suspect it, which biochemical test should be applied, how do you go about imaging this patients with phaeochromocytoma, the additional incremental value which is brought in by the functional imaging, the preoperative management, and the genetic profiling of these individual towards then using surveillance-based protocols for management of the family members. That's what was sort of alluded to in the discussion so far. If there are any questions to our panelists, I'm sure they'll be very, very happy to take them. So is there any question, please? Hi. Hello. Yeah.
Wayne Cutfield from New Zealand. Really interesting case and very helpful panel discussion. A comment back to you, Steve. You made the comment when you were talking about surveillance with younger children, and that if their biochemistry is normal, you were opting to chest and abdominal ultrasound patients. And it's interesting how our practices are forged by single incidences or cases. We had an 8 or 9-year-old girl, had an SDHB mutation, and she had negative biochemistry in follow-up, and then was having biennial abdominal and chest MRIs. Somehow in the communication, the neck was missed out, and bingo, up popped a very large cervical lesion. So even in younger children, I'm cautious and doing base of skull to pelvis imaging, but that's based on one case.
Yeah. I mean, Margaret, you also had a similar experience that you shared with us earlier. Would you like to comment on that?
Yes, it was a 7-year-old boy with an SDHB mutation who had an enormous lesion in the pelvic area, which would have been missed and had been missed on previous ultrasonography. So I think I feel like Wayne that I prefer to have an MRI base of skull to pelvis at least every second year, and we alternate with the ultrasonography.
Yeah, I suppose, Steve, perhaps we all have kind of worked around our own set of experience and probably are governed by the worst case scenarios which we've handled, and we've been so bruised with them that I think we are erring on the side of safety. But logistically, MRIs being done alternate year from head to toe are a bit of a challenge, because the younger children, we need to put them under sedation, and they take away a very big time chunk from the MRI list. So our radiologists are not very happy to accommodate them, but we are working towards that. So is there any other comment from the right? So I think Maria, please.
Going back to much earlier in the discussion, this issue of urinary versus plasma metanephrines and normetanephrines. Again, my experience isn't huge, but it's just so much easier to do the plasma samples. There are some logistical issues, and often they want the kids, calm and well rested. But I would very much argue that urine testing is not ideal.
So if there are no more questions, I think I'd like to invite sort of thought processes and comments from the three respective presidents towards special interest group-based meetings, and what is their way forwards and their future. How do they foresee that? So Maria, can we start with you?
Well, I'm delighted to be here. I haven't really contributed very much, but APIS is very supportive of special interest group meetings. We, over the years within APIS, and there's a number of quite senior APIS people in the audience, including Wayne, we've certainly been very supportive of running special interest group meetings, and of course, post-COVID, we're all very used to doing them via Zoom. We'd have to, I don't know if Lindell's here in the audience, but we can certainly have the Secretariat organise them. I know I'm speaking for her, but they're straightforward to organise, and I think it's a great idea.
Lovely.
Yeah. And we have another council meeting. So we've just literally finished council. We've got a new council starting. So we've got a council meeting bright and early on Saturday morning. Very, very happy to discuss it then.
That's great to hear. And I must acknowledge the support of APIS and ISPE in putting together this meeting of a special interest group towards phaeochromocytoma and paraganglioma. So, Maria, thank you for that. And Ahila, what would you consider is the way forwards? How should we go about it? What do you think about it? What do you think is the way future of SIGs?
Thank you so much. It was a wonderful discussion. And in India, we have huge volume of patients, like how Dr. Shah talked about 650 paragangliomas. And when all our numbers are in thousands, but I don't think we have ever got them together and having a special interest group to formulate ideas. And it's also helpful for people in the periphery. It's a huge country and people are lost and they would appreciate the support they would get from a special interest group. And I think this is the way forward. And you're paving the way for several special interest groups. And I think thank you so much for starting this off.
Oh, that's a great support, Ahila. And I truly believe that it's a platform to share your strengths, and maybe it has then several milestones ahead which can be accrued, but there is really no hurry, one baby step at a time, really. And Jenny, it's time to understand what you think of this particular aspect of special interest group. It's not necessarily just FEO we are talking about, but being the president-elect, how do you foresee this particular domain of work being furthered?
Thank you, Professor. It's a really good opportunity to be here. And I think the SI, special interest group, is very, very important and also attractive. I think it's a very good opportunity to bring multidisciplinary doctors together. Like the PPGR, we are not just pediatric endocrinologists, but also surgeons and also like healthcare and genetics. So it's really a good, I would say it's a really good way to bring us together. And I think in the future, I will agree with Maria. So we, as the APAS, will totally very supportive to the SIG. And I'm pretty sure that SIG will getting better in the future if we can bring all together the APAS or worldwide specialists together to just discuss some specialized interesting problem. So it's really helpful. Thank you very much. I'm really enjoying it.
Thank you, Jenny. I'm sorry we missed your presence in person over here, but you are around on a virtual platform, which is a great thing. So thank you, everyone. Thank you, Steve, for joining us. I know you're in the middle of another meeting, but making time for this. Thank you so much for joining. Thank you, Rory, for joining this particular meeting. And my own Vijay, thank you. Manjri, thank you very much. And all of you, I knew you had all other competing two very nice SIGs going on, and you chose to be present for this particular area of phaeochromocytoma and paraganglioma. Thank you very much for coming.
Thank you. Bye-bye.
Thank you.
Thank you. Thank you.
Congratulations and a great start. And I hope ISPE goes the same way in several things.
So I remember, if I can make the final comment, I remember, Nalina, you've spoken at many APIS meetings and fellow schools over the year, and I remember once you spoke about Cushing's syndrome and you'd seen like 80 cases or probably more than that. But I do think we need to recognise that countries with big populations and hundreds of patients can really help us as a global community learn. So thank you.
A pleasure, Maria. Thank you.
Thank you.
I would like to thank our moderator, Professor Nalini Sameer Madam, for the smooth conduction of this informative session. Your insights have greatly enriched this discussion, Madam, and we are really thankful to you. And we also thank our esteemed speakers, panelists, and chairpersons, and the case presenter for this session. I request the panel to please proceed towards the felicitation area, and I request our audience to please proceed for lunch. Thank you.